When you get a genetic test result back, it's never really the end of the story, is it? It's more like the start of a whole new chapter. It's not a simple yes or no answer. It's this incredibly complex language that honestly we're all still learning how to read.
And that new chapter, it almost always kicks off with this one huge question. A question that both doctors and families are wrestling with. Okay, the test found a change in the genetic code, a variant they call it. So what does that actually mean for someone's health?
Because we have to remember behind every single one of these data points, there are real people, real families, just desperate for answers. And for so many, this is the very beginning of what's known as the diagnostic odyssey. I mean, this is a journey that can stretch on for years, filled with endless tests and specialist visits, all in the hope of finding just a little bit of clarity. The thing is, with the technology we have today, we can read our genetic code in ways that were just science fiction a decade ago. But that creates a whole new kind of challenge. We're now finding all these super rare changes that get slapped with this label variants of uncertain significance, or VUS for short. It's like finding a typo in the book of your life, but you have absolutely no idea if that typo changes the story or if it's just, a harmless little mistake.
So the big question is, how do we turn that confusing typo into a clear path forward? Well, that's what we're going to break down. We'll follow this kind of four-station journey. We'll look at how the odyssey begins, how experts use a rulebook, how they move beyond labels to probabilities, and how all that data turns into a real conversation. Then we'll wrap up with four key principles.
All right, so let's start our journey right here with this giant genetic question mark. What is a variant of uncertain significance, really? And why is it such a huge deal in genetics today? Okay, so scientists have this five-tier system for classifying these genetic changes. On one end, you've got benign, totally harmless. On the other end, pathogenic. Yep, this one is known to cause disease. And then, smack dab in the middle, you have VUS. It's the ultimate gray area, the zone where we just don't have enough evidence to lean one way or the other.
So how do we start to tackle that uncertainty? Let's head to our first station, classification. This is where scientists try to bring some order to the chaos by using a standardized framework. Think of it like a rulebook for the genome. This rulebook actually comes from the American College of Medical Genetics and Genomics. And it basically tells experts how to play detective. They have to gather all these different lines of evidence. For instance, they'll ask, how often does this variant pop up in the general population? What do our computer models predict it's doing to the protein? Can we see in a lab that it's messing with a cell's function? And this one's huge, does it seem to travel with the disease through a family's history? And sometimes, this system works like a charm. Take a well-understood condition like neurofibromatosis type 1. A known pathogenic variant shows up, it perfectly matches the patient's symptoms, all the clues line up. The rulebook leads straight to a competent diagnosis, case closed. But here's where it gets really tricky. Even when you get a pathogenic label, that's not always the end of the story. What happens when having that variant doesn't mean you're 100% guaranteed to get sick? Well, that brings us to our second station, quantification. This is where we have to shift our thinking from black and white categories to the nuances of probability. And the key word here, the concept you absolutely need to understand, is penetrance. It's just a fancy term for the probability that a person with a specific variant will actually develop the disease. The loaded gun analogy is perfect. Having the variant carries risk, for sure, but it's no guarantee it'll ever go off. And this is so important. This is the fundamental shift we're talking about. We have to move from just a label, a category, to talking about probability. What is this person's actual individual risk? So how do they do that? Well, this is where a really cool tool called Bayesian logic comes into play. It's kind of like starting with a really blurry, out-of-focus photo. That's our initial vague belief. You can see it in that wide, flat curve on the left. But then, as we add more and more evidence, piece by piece, that picture starts to come into focus. And we end up with a much sharper, more confident probability, that tall, narrow peak you see on the right. It's all about refining our uncertainty. Okay, so we've got this data, this probability that's getting clearer and clearer, but data on a screen is one thing. How does that turn into something a family can actually use to make decisions? Well, that takes us to our last couple of stations, deliberation and communication. How do the experts make sense of it all, and how do they talk about it? First off, interpreting a variant is absolutely not a solo sport. It takes a whole team, a genetic, multidisciplinary team. You've got geneticists, scientists, counselors, all huddled around the table, literally putting the puzzle pieces together. And they're all focused on answering that one critical question. Does this specific genetic finding actually explain what's going on with this patient?
And that brings us to the final and maybe most important step, the counseling session itself. And broadly speaking, there are two ways this can go. You have the teaching model, which is pretty much what it sounds like. Its goal is just to transfer information. But then you have the counseling model, which has a much deeper goal, to help patients make sense of that information, to find personal meaning in it for their own lives. So which model do you think wins out in the real world? Well, what actually happens inside that counseling room might really surprise you. A huge study found that, on average, counselors talk 5 times more than their clients. 5 to 1. The session is just dominated by this one-way flow of information. And right there, that's the huge disconnect. That 5 to 1 talk ratio has real-world consequences. Because when you actually ask patients what they found helpful, they are way, way more satisfied with counseling that focuses on support, on the psychosocial side of things. It's not even close. They feel best when they feel heard, not just lectured at. So why does this happen? Why is there this gap? Well, this quote from a supervisor really nails it. It's something called the counselor's dilemma. There's this very real fear of opening up an emotional can of worms. You know, in a packed clinic with back-to-back appointments, it can feel so much safer and faster to just stick to the data, even when helping the patient navigate their emotions is what they need and value the most. Okay, so after going on this whole journey, from a single variant on a report all the way to a deeply personal conversation, what's the takeaway? What's the big picture here? What have we learned about how to navigate this brave new world of genetic medicine? It really comes down to 4 key principles. Number 1, we've got to embrace probability instead of clinging to simple black and white labels. 2, we need to look at the whole clinical picture, not just the single gene. 3, this has to be a team sport. Collaborate holistically, don't work in silos. And number 4, and this is the big one, counsel for meaning, not just for information. Empower patients to make sense of it all. Because at the end of the day, interpreting a genetic test is about so much more than just data. It's about translation. The real goal isn't just to read the code, it's to help a family write their next chapter. It makes you think, doesn't it? Maybe the biggest hurdle we face isn't in our technology anymore, but in our very human ability to translate all that incredible data into real, actionable meaning for the people who need it most.